Hello, and welcome to Your Health Matters. My name is Dr. Peter Hogenkamp, and today on the program, I have the great pleasure of welcoming Dr. Mark Levine, the State Health Commissioner for our wonderful state. Dr. Levine, welcome to the program.
Thanks very much, Peter.
So I wanted to start off by thanking you for spending some of your time to join us today. And with cold and flu season coming on us here in early November in Vermont, and with COVID season being right in the middle of, I thought we would start off by giving me your thoughts on where we are right now with the COVID virus in the state of Vermont.
Sure. As you know, we have done so well. We have been and still are the state with the lowest new cases per population on a daily basis and the lowest test positivity rate.
That's fantastic.
Having said that, the storm clouds are gathering. And clearly, if we look at the national picture, where we know that a vast majority of states are having a worsening pattern, and even if we look at the regional picture, where the Northeast, as you know, had done very well after its initial traumatic entry into the pandemic, right. The region is also going much worse. So if we look at Vermont, we're accustomed in Vermont to seeing cases in the single digits per day,
right?
Maybe in the low teens. Now the more normal days are in the higher teens and in the 20s. That concerns us, obviously. It's not in the hundreds or 1,000 like other states, but it's a lot for us. And as we look at the number of outbreaks and clusters and just random cases that we're following, we notice that they're geographically dispersed across the state, and there are more of them. And there are not only more cases, but each case over time now has more contacts associated with it, so that the amount of work that the contact tracing teams have to do is much more increased than it ever has been before. So we're very, very cautious and concerned about this, not panicking by any means, but we're noticing that we are now joining a growing trend around the country and unfortunately the world for that matter.
Right. So what measures are we using here in the state to battle the spread of the virus?
So the main measure we're using when we know where the virus is that policy that's called containment.
Right.
And containment is really fundamental public health when it comes to infectious diseases like the flu, like this coronavirus. Starts out with having the capacity to do testing and having an entire testing infrastructure that's established and set up, which we have.
Right.
That's how you identify the cases. We then move into isolating those people who have tested positive, doing contact tracing and interviewing of all those cases so that we can then interview the contacts and let them know that they, in fact, need to quarantine because they've been exposed to a case. So that's the fundamental strategy, but it's built on this other strategy that we kind of term simplified guidance, which is telling people how to live their lives in a pandemic. And it's all the stuff we've talked about day by day, week by week for months and months now. And it all has to do with staying away from others when you're sick, washing your hands, keeping good respiratory etiquette, keeping good physical distancing, but as I always say, but connecting socially, wearing a mask. And the newest wrinkle is making sure that you're not putting yourself in crowded indoor situations, which of course is why the virus is thriving around the country now in the fall as we get into the winter. So, we've really been focusing all of our recent energy on containment, crowds, and travel. And that seems to be the focus of what we have to do, along with trying to do more testing in what I call a surveillance strategy, not just testing people who feel ill or who think they may have been in contact with someone, but testing people perhaps because of the profession they're in, being higher risk and more public facing, and having a regular strategy so that we can understand the virus and how it's penetrated our communities a little better, since we know that so many people have few to no symptoms, even when they might be at their peak of infectivity.
I went last week to get a test just because, seeing patients like I do, I figured it was a good idea. And I also wanted to get a sense of the process. And at the Rutland Hospital, they're doing a wonderful job. My test was back in 24 hours. And that's one of the great things that we've noticed about here. What we're doing in Rutland County is I get my test back very quickly, because the utility of a test that comes back in 24 hours is far greater than the utility of a test that takes 4 days for it to come back.
Where it almost has no utility.
Where it has almost no utility at all. And I'll be happy to tell you that in the few cases that we've had among our patients, I always call them up and inquire, were you called by the health department? Are they contact tracing? And that's one of the things that we've done, I think, so well, is the wonderful follow-up. Because if you identify a person who has COVID, but you're not identifying the contacts, you've done no good.
Exactly. And I can just put a little plug in here that our contact tracing team and effort has really been called out by the CDC as one of the leaders in the country.
Right. I was doing a program yesterday with a friend of mine from North Carolina, and he was actually asking me these questions like, what are you guys doing so well in Vermont? So being a proud Vermonter, I was very happy to see that we were getting the national recognition for that kind of thing. So let me ask you a new question. Now that we're going into the cold and flu season, where, again, this is always a problem for us as people spend less time out of doors and more time clustered inside. Are there any additional measures that you're thinking of?
I think it's going to be just the emphasis I mentioned on the fact that the enemy now is people getting together in crowded situations. Yeah. So, we have like wedding guidance that says you can be indoors with 75 people. And that can be in a very large facility where you actually can do that and physically distance, have good ventilation, and wear masks, except when you're eating or drinking. And you can be pretty safe, actually, sometimes. Maybe safer than when you're in your own house and you've invited 15 people to sit around the Thanksgiving table in your dining room, where they're not going to wear a mask because they're eating their meal. And it's going to be hard to socially distance in a house that's an average size in Vermont. Right. So we're really trying to, again, not be the Grinch, but at the same time, let people understand that this virus is thriving right now. And it's thriving because we allow it to be in the conditions that would allow it to thrive. And in the beginning of the pandemic, we always talked about trusted households. So as people were coming out of that stay-at-home stance where they couldn't even leave their house, and we were trying to let them get back to see, relatives, see friends, we used the trusted household. And that was okay because the suppression of the virus was so good that they weren't going to encounter it very often. But now as it's becoming more prevalent, even the trusted household is a little more of a nebulous concept, right? Because the people would be trusted by you for anything else in your life, but they can't control the fact that the circumstances they find themselves in, whether it's at their work site or in their community in general, could allow them to be exposed to the virus and then be at your house that day in an asymptomatic stage, transmitting the virus. So we're really, messaging around that and messaging around almost a self-restriction of travel, because we are quite aware of the fact that the virus is so much more prevalent everywhere around us, on all of our borders. And unless you have really good reasons to travel, you really have to reconsider that, or at least do it, but adhere to the quarantine guidelines when you've come back.
Right. You were talking about an issue, and my patients have mentioned the same thing to me. Everybody uses the expression their own personal bubble. Yes. He's in my bubble, and that's what you're talking about, those trusted families and things like that. And I keep on pointing out to them, the same point you were making, and that is, as the virus kind of comes in and kind of crowds into us, we have to reevaluate our personal bubbles, because it's just so hard to know who they've been exposed to and go from there. Let me ask you something. There's a lot of indicators of viral activity. There's the transmissibility rate, there's the the positivity rate of testing, there's this active case rate per 100,000, obviously hospitalization rate, mortality rate. What do you look at in terms of trying to assess how this virus is affecting our state right now?
All of the above, because these are really all great indicators, and they help us not only understand ourselves, but compare ourselves to the region and to the greater nation.
You were talking about the positivity rate that we're doing so well with. And just, to a layman, the positivity rate is just the number of tests that test positive.
Right. So it's a ratio of...
A ratio, correct, yeah.
Yes.
And we were, what, 2%?
Oh, at some weeks we've been 0.5%.
Right.
I think overall we're still less than 1%, but it's increasing over time.
Right.
But obviously, a place like New Jersey, not to pick on them, but they're in our region of the Northeast, they've just surpassed 6%.
Wow.
And they had done a really good job, just like New York City, of really crushing the virus during those months after the spring. A state like South Dakota, where they've been very laissez-faire about their approach, and they have 1,000 cases a day, their percent positivity is above 40%.
That's incredible for me.
That is. The northern New England states have tried to keep it below a couple percent, which is really good. But that's an indicator I would call a current indicator, just like the number of new cases and our viral growth rate, if you will. There are lagging indicators like deaths and hospitalizations that we still look at every day with a laser focus. But once those start moving, we would hopefully have already expected them to move, because we had the other indicators telling us trouble is brewing.
Right.
So,
and I have patients that ask me, like, well, what's the point, of positivity rate and case rate? Aren't those just those meaningless numbers? And I'm like, well, they all then 2 to 4 weeks later, they become active hospitalization rate and mortality. And,
exactly.
And those are obviously, very, very valid numbers. And we're trying to keep those numbers down.
You got it.
I was talking to another person the other day, and he was saying, well, I thought the original goal of our efforts were to flatten the curve and to keep our hospitals from being overwhelmed, as opposed to just kind of completely eradicating the virus. So what would you say to that question?
That was framed exactly correctly. We were trying to flatten the curve to prevent the healthcare system from being overwhelmed by cases, and then more people dying because they couldn't get the care that they needed,
right?
Or that the hospitals were just unable to cater to everybody. And we would have what we call a surge and need overflow beds and all kinds of other facilities developed. So that was our emphasis. Never have we had eradication of the virus as the outcome measure that we would want to pivot upon.
Because it's impossible.
Totally impossible. It's on the planet. It's not going anywhere. The goal is that more and more people will have antibodies against it because they've encountered it. A vaccine will come along, or many vaccines will come along, providing more immunity to those individuals who receive it. And so the virus, though it's here, just won't be affecting and impacting so many people or the healthcare system, because they're not as susceptible to it anymore.
Right.
So
and I try to tell my patients, it's hard to explain to them, having not gone through microbiology as you and I did, what the difference between a bacteria and a virus is. But I tell them, the virus is a particle that doesn't live on its own. It needs a host. And if, for instance, everyone were to hide in a hole in the ground for 2 weeks, viral transmission would be gone and the virus would be dead. But obviously that's impossible. So we're just trying to find some kind of middle ground, keep the virus at bay, and give our scientists time to come up with this vaccine, which is a good segue into my next question. And that is, what do you know about the vaccine and where we are with that?
Yeah, so I know as much as anybody. Maybe I have a little inside line on a couple of things. I know that there are a significant number of trials that are at the phase 3 level, which is the level you want them at to really evaluate the efficacy and the safety of the vaccine. Those trials, though, if they show success, the FDA has said they want to see 3 months of ongoing immunity and success through the study period. So though people keep talking about a vaccine being authorized for emergency use before the end of the year, and though we are planning for that because we don't want to miss the boat if it is available, I'm not super optimistic, but I'm thinking there could be one perhaps candidate that makes it through all of its rigorous trials and gets approved and authorized for use. If that happens, we'll probably get hundreds of doses in Vermont. We will not get 600,000 doses. And we will have to be very strict about how those are prioritized and given to the population, and have an idea of how many more will be coming in at whatever intervals. If a number of vaccines get authorized at the same time, it gets more complicated because you have to understand what makes one different than the other, maybe better than the other or whatever, and how to account for the fact that people will need 2 doses for most of them and make sure they get the right first dose and second dose of the same vaccine. But the reality is we'd love to have that problem if we have enough candidates come through successfully, because that means there'll be more vaccine per capita in Vermont.
Yeah. And on that same kind of note, what about treatment measures? Have we made some progress in treating the virus?
We have. But for the majority of people who are going to be staying at home when they're sick and maybe seeing us as outpatients, but not in the hospital, there's nothing new that's happened with them, really.
There's no new outpatient treatments.
No new drug or anything of that sort. There is obviously something we're doing at the health department, providing everybody who wants it with an oximeter. You know, an oximeter for the broader audience here is just basically something you can put on your finger and it lets you know the oxygen level in your blood. And that can be an early warning sign that someone's deteriorating.
Getting into trouble. Yeah.
And with COVID, the curious part is people don't actually know that's happening to them. They think they're doing fine, yet their oxygen has transitioned from 96% to 86%, and they didn't notice it. So this is an important warning sign that might allow you to do supplemental oxygen at the very least in those individuals. So there's an advance there. With regard to the actual treatments, they are reserved for the inpatient setting and almost universally for the very sick. Though remdesivir, which is an antiviral drug, did just get authorized for anyone who's sick enough to be in the hospital. But that doesn't mean you're on a ventilator in the intensive care unit. You might just be sick enough to be in the hospital, need oxygen, what have you. Remdesivir will not improve your survival, but it may lessen the severity and duration of your illness. For those in the very sick end of the spectrum in the ICU, dexamethasone has been an extraordinary drug for improving people's outcome, probably because it interferes with that cascade of inflammatory mediators that are activated by the coronavirus infection itself. The other thing that's very promising now is the monoclonal antibody treatments, which were made famous when the president, I think, was in the hospital. Yeah. But there's still, possibilities. And then just general intensive care of people. A lot has been learned from the early experience. And now, when it comes to the timing of putting people on ventilators, the timing of using oxygen, how it's delivered, the positioning of the people in a prone position, the tidal volume that the ventilator delivers, when you use a blood thinner, an anticoagulant, because blood clots are seen frequently with coronavirus. All of these things are becoming much clearer to the clinical community, and I think leading to much better outcomes in those who unfortunately have to get hospitalized.
But I like your point before you were making about there is nothing in the outpatient setting, and that again is the majority of patients are going to be treated, by me or you in our offices. For those folks who aren't in the hospital, there really is nothing new. And again, most of these folks will not get seriously ill.
Right. It's kind of like influenza, where most people who we see with influenza, we just say, go home and rest and drink plenty of fluids and take something for your fever, etc. And there's a number of them that we do have a drug for, but Tamiflu. But at the same time, we're not treating everybody with Tamiflu. And we know that Tamiflu isn't necessarily saving their life. It's just perhaps getting them back to work a half a day sooner.
Correct, yeah. And I use Tamiflu pretty well for prophylaxis of household contacts as well.
Yes. And we don't have that with COVID, but it's a similar approach.
Yeah.
The thing I am worried about, though, is there are some of these people that never make it to the hospital and don't need to, but they report persistent symptoms over many, many months. And they've been called long haulers by some, and we don't understand them very well. We don't even understand the spectrum of illness they present with because it's very individualized. Some of them look like people who have what we called chronic fatigue syndrome in the past. Others have other symptoms that just won't relent. And they're clearly impacted by this. And we don't know yet, because it's only been 8 or 9 months into this pandemic, what percentage of the people who've gotten the disease have this, and how long it might last, and what you can do about it. So we're paying a lot of attention to that, but nationally, not just Vermont, to try to understand it better. But our hope is still that the majority of people who don't have to enter the hospital have a more benign disease, and they get through this, and then they're done, and they can function again.
Great. All right. So in the few minutes that we have left, give me your thoughts about where we're going in the next couple of months. From the way I look at it is, we're trying to give the vaccine makers some time to get this going. But in the meantime, we should continue what we're doing very successfully, I will add. Keep social distancing, keep washing our hands, keeping our hands away from our face, that kind of thing.
Yeah, it's what I call the dual pathway. Everybody still adheres to all of the things you said that we've been talking about forever without letting up. No pandemic fatigue here, no time for that. And at the same time, we start, this is aspirational, but we start gradually immunizing the population with the vaccines as they become available, and as they become available in greater numbers.
In greater numbers.
Through both pathways together, we all make it to the other side of the tunnel, which is a return to a life that we could consider more normal, if I could use that word.
Yeah. I would love to go back out to dinner again.
Yeah, right. I enjoyed going out to dinner when the weather was warm and sitting in tents and things of that sort. And that was great. And I'm still trying to support my local restaurants with takeout as much as I can.
Right. That's a great point. Well, listen, thank you very much. It's been wonderful. One of the reasons I enjoy this program is I get to learn a lot from people like you. So thank you very much for taking the time with us today. And I look forward to speaking again in the future.
Thank you very much, Peter, for having me on.
All right. Cheers. Mark, thanks again. Bye-bye.
Take care.